So today we are going to talk about um, very which is the subject which we are going to talk today is not usually taught, but I think it is also important for us to understand, especially as people who are working in palliative care. So I would share my presentation. Okay, today we are planning to cover um, methadone only, and some of you might have heard about methadone, and many of you may not have heard about methadone. Probably you have read it during your pharmacology days. So we would be looking at the pharmacological properties of methadone because it is different from other opiates that you have learned, like methadone, sorry, morphine or fentanyl or any other opioids. So this is an entirely different opioid. So it is important for us to understand the pharmacological properties. And some of you might have heard about methadone can produce some serious side effects, and you might be concerned about that. So we have to look into the benefits of using methadone and what are the complications that can be produced by using methadone, and how to get a balance in this. Then during administration, we need to know how we should monitor a patient while he or she is on methadone. And another thing, even if you learned about methadone, many people say that I do not have a appropriate patient to start methadone. So we need to understand what are the situations or who are the patients for whom we can start methadone. And most importantly, how you would convert an opioid to methadone, because there would be various methods available, but we have to see which would be the safest one. Okay, so with this introduction, um, and probably you may also know that methadone was not available for as an analgesic till 2018. Till then, it was used as an oral substitution therapy, even in India, but it is used as an analgesic since 2018 in India. Okay. Um, so we would first discuss a patient story, and I would appreciate your um, response for these questions which I am going to ask. So we have a 30-year-old woman who is diagnosed with Ewing sarcoma. So this was first started as a small swelling at the sacral area in 2016, and she was complaining of pain on her back. And it was diagnosed as Ewing sarcoma, and she received chemotherapy and radiotherapy for the same. So for the next 2 years, she was comparatively pain-free, but again, she had pain which was started on her back and was radiating to legs in 2018. So the oncologist advised an MRI, which showed that the disease is progressing, and you can see the S1 vertebral body is involved, and there is compression of L5 and S1 nerve root, and PET scan showed pleural metastasis. So that means the Ewing sarcoma is progressing. So this is the pain that she's describing. So this pain is at the back. You can see at the lower back, she's complaining of pain. Even though it is marked as patchy on the right leg, on the back, probably it should be continuous. But um, she was complaining like burning and shooting type of pain, which um, she is getting some relief on lying down. but it increases with any movement. So because of this problem, she is actually restricted to a bed, and she was on the first floor of a house. So um, she was unable to move, and she was in the bed. And because of this pain, she was unable to sleep, unable to take food, so many things. So you can see a patient with severe pain, and that also, even with movement, it goes on increasing. And the pain score which is marked here is pain at rest. So with each moment, her pain is going to 10 by 10. Okay. So these are the treatment she received. She was getting, as you know, for severe pain, we would give morphine. And from the description of the pain, what type of pain she is experiencing? Anybody please unmute and speak, or else you can give your answer in the chat box. What is the type of pain she is experiencing?
Is it a neuropathic pain?
Yeah. Can you tell me why you are saying it is neuropathic pain?
Because the pain is radiating down the course of the nerve.
Yes.
It's like
Yeah, there are many features which indicates that she has neuropathic pain. So one is there is a history of a disease. From the MRI, we know that there is compression of L5 and S1 nerve root. So that is something which, the first criteria to understand whether it is a neuropathic pain is that there should be a history suggestive of a lesion or disease affecting somatosensory nervous system. So in this patient, it is there. Then it should be in neurodermatomal distribution. So she's complaining of pain entirely on the back of her right lower limb. Then the quality of pain, it is shooting and burning, which is typical of neuropathic pain. Okay. So she was getting amitriptyline, pregabalin, morphine, and she received dexamethasone. So with this, she had no pain relief. She was still unable to move. So what would you do for this patient? Or how would you treat this patient if this patient is going to be taken care of by you? So dexamethasone was given. Actually, this was not given by us, but I understand that because of nerve compression, there should be some very nerve edema, which can be reduced by giving dexamethasone. Anybody, how would you treat this patient's pain? Because he has no pain relief with all the above medications.
Would a nerve block work?
Okay, nerve block. Okay. Yeah. Anybody else? Fentanyl patch. Fentanyl patch. Okay, Dr. Dilip. Dr. Dilip, why do you say fentanyl patch can be used? What would be its advantage over morphine?
So it is much more potent.
Sorry, we couldn't hear you.
It is much more potent than morphine.
Yeah, that's right. It is much more potent than morphine. Uh, but mostly, if somebody has a pain and if it has, it is not, if it does not provide pain relief with morphine, and especially in the patient with neuropathic pain, and the probability of getting pain relief with fentanyl is least likely, but I am not telling it is 100%. It is least likely.
And gabapentin at night will help.
Yeah, here she's already on pregabalin, so which is again a gabapentinoid. So you can see she's getting a tricyclic antidepressant and gabapentinoids, which I think is a very good dosage or optimal dosage. So, switching from pregabalin to gabapentin may not be, I'm not sure, but still, I think it may not give such pain relief. I'm sure there are many anesthetists in this group, and what are their idea about giving pain relief for these patients? Anybody? Okay, anyway, this patient, yeah, Dr. Ravindra says epidural. Yeah, this patient was also under the treatment of an anesthetist. So he was doing these things and no pain relief. So he also thought the same way that just now you mentioned. He put an epidural with opiocaine and morphine. Initially, the patient had some pain relief, but even this some pain relief was important for the patient because she was suffering for a long time. So this anesthetist thought that okay, all of you know that we cannot put epidural for long time. So he was reciting this epidural site, and he continued to keep this epidural catheter in place almost for 2 months. But as the days went on, the effect of epidural analgesia is also became less. She was not getting that much pain relief. So after about 2 months, the anesthetist thought of taking epidural, and he started her on oral morphine again. So this time he started her with the 20 milligram of morphine 4 hourly and SOS, and he removed the epidural catheter and increased the dose of morphine in the subsequent days, and also added again tricyclic antidepressant, amitriptyline, and pregabalin. But again, no satisfactory pain relief, and the patient developed delirium and myoclonus. So how can we now go forward in this situation? And what does this indicate? The patient developed delirium and myoclonus. What does that mean?
These are toxic side effects of morphine.
Yeah, so that means you cannot further increase the dose of morphine, isn't it? So how are we going to manage this patient now? Switch to methadone. Okay. Okay. So as Dr. Ravindra said, this was the time when this patient came to us, and the methadone was just available to us. So we thought that okay, this patient would be a good candidate to start on methadone. But even if we are going to start methadone, we have had many things about methadone, and we have had a few classes on methadone, but we were not sure how to start what, which method should be used. when we looked at the literature, there were too many methods how to convert from an opioid to methadone. And these are the methods that has been described. The 3DS, that means 3-day switch. Then a rapid conversion stop and go method, ad libitum stop and go method, German model, outpatient titration. So we were confused. But those who taught us, they were mainly talking about 3-day switch. Okay. So, but before you convert morphine to methadone, you need to know how much methadone should be used. So for this, you have to use an equianalgesic table. And this was the table which was used in 2018. So you can see if the dose of morphine is less than 30 milligram, then the potency is 2:1. That means you have to start on 15 milligram of methadone. And depending on the dosage of morphine, the dosage of methadone also varies. But in case of other opioids like tramadol, fentanyl, you say it is 100 times more potent than morphine. So it has a linear relationship with the dosage of opioid. But here there is no linear relationship. Whereas here, according to the dose of morphine, the potency of methadone varies. Okay. So in this patient, we calculated the dose of methadone. MADD means it is morphine equivalent daily dosage. So she was getting 40 milligram every 4 hourly. That means she was getting 240 milligram of morphine per day. And if you look at the equianalgesic conversion table, you can see she's taking morphine between 100 to 299 milligrams. So the potency is 8. So you have to divide 240 divided by 8, that is 30 milligram. And when you convert from an opioid to another opioid, you need not give the full converted dose, as there is some difference which is going to happen at the receptor level. Various opioids acts differently at receptors. So you have to reduce 30%, which is known as incomplete cross tolerance. So for incomplete cross tolerance, we have to reduce 30%. That 30% of 30 milligram is 9, isn't it? And then you have to calculate the dose of methadone, that is 21 milligram. So this is the dose with which we have to start the patient on methadone, 21 milligram. So if you use the 3-day switch method, it will look like this. So on the first day, you have to give 1/3 of the methadone. You calculated total 21 milligram. So 1/3 would be 7 milligram. So you start 7 milligram on the first day, but at the same time, you have to reduce the morphine by 1/3. On the second day, you would add another 1/3 of methadone and reduce another 1/3 of morphine. And on that day 3, you will convert whole morphine into methadone. So total 21 milligram of methadone you would give on the day 3, whereas you would stop morphine. So by taking 3 days, now you have converted the morphine into methadone. So this is known as 3-day switch. Okay. So this is what is described in literature. But we actually, what we did was, on the day 1, we gave 1/3 of the total methadone, that is 7.5 milligram of methadone. And we reduced the morphine by 1/3. But as per literature, we have to now add another 1/3 of methadone on day 2. But instead, we waited till day 7 because we were not, this was a new drug and none of us were experienced in using methadone. So we were very afraid to use it in that manner. So that's why we waited till day 7 and we increased it to 5 milligram TID and reduced the morphine by another 1/3. So by day 7, her pain was improved. She could sleep and she is able to move in the bed. But by day 14, that means after about 2 weeks, this patient came to our OPD. So this patient was actually, I told you, was in the first floor of a house who was literally restricted to the bed. But now this patient came to our OPD by walking. So that was the effect of methadone. Um, Methadone, okay. So, um, so why did this patient got good pain relief? Even though she was tried on morphine, she was tried on tricyclic antidepressant, pregabalin, dexamethasone, many other medications, epidural analgesia. But what made this patient to have good pain relief? So for that, we have to understand the pharmacology of methadone. Okay, so methadone is available as a mixture of R methadone and S methadone, and it acts on all the opioid receptors, mu, kappa, and delta, as an opioid agonist. You know that morphine and fentanyl is a mu agonist, whereas here methadone acts on all the receptors as an agonist. It has an NMDA antagonistic property. So, which is the other medication which you know has good NMDA antagonistic action? Another medication which has good NMDA antagonistic action.
Ketamine.
Yeah, ketamine. Yeah, NMDA is N-methyl D-aspartate. And it methadone also inhibits the reuptake of noradrenaline and serotonin. So, which other group of medication has this property of inhibition of reuptake of noradrenaline and serotonin?
Antidepressants.
Which group of antidepressants?
Antidepressants like metrazapine,
Yeah.
SNRIs.
Okay, tricyclic antidepressants. Okay, or SNRIs. So tricyclic antidepressants like amitriptyline, imipramine, nortriptyline, duloxetine, all those have serotonin and noradrenaline reuptake inhibition property. So you can see that it acts like an opioid, it acts like an NMDA antagonist, it acts like a tricyclic antidepressant. So it has three properties, but it also has another property which in which it blocks a human either a go-go related gene channel, and it can produce torsades. So what's the problem if the patient has torsades? It can cause sudden death, isn't it? So you can see the first three properties which are beneficial, whereas the last one is very fatal, which can lead to death of the patient. Okay, now we will see each property. So you know that methadone acts on all the opioid receptors as an agonist. So because of that, patient will have all the physiological effects of physiological effects of uh, physiological effect when acting on opioid receptor. So naturally, it will produce analgesic effect. It can produce constipation, nausea, vomiting, respiratory depression if it becomes uh, in larger doses, sedation, so many things. So all the physiological properties. Okay. And the second property we said was NMDA antagonism. So here you can see there are 4 patients who are taking large amounts of opioid. If it is in morphine equivalent dose, the patient is taking about 1000 milligram of morphine C is taking 3000 milligram, patient B is taking 7000 milligram, and patient A is taking 12,000 milligram of morphine equivalent. Um, so, can anybody tell me what is tolerance? What do you mean by tolerance?
The patient needs more dose eventually.
Uh, okay. So suppose a patient a patient is getting higher doses for the same effect. Yeah, that's right. So a patient who had pain, you started him on 5 milligram of morphine 4 hourly. But after some time, his dose went up to 10 milligram 4 hourly to get the same pain relief. And after some time to 20 milligram, then to 30 milligram, 40 milligram, 100 milligram 4 hourly to get the same pain, to get the same effect. So that's what is known as tolerance. So here you can see here probably these patients are. Have you ever seen such patients who are on this much higher doses of morphine equivalent opioids? I have seen, or my experience is that I have had a patient who was taking for 50 milligram of morphine every 4 hourly. That was the highest maximum that I have used in my experience. So here patients are taking morphine in terms of thousands of milligrams. So probably these patients were taking this much higher dose because they also had tolerance. Okay. And here all these patients were started on methadone 30 milligram, 10 milligram every 8 hourly TDS. And all these patients had very good pain relief. So regardless of the dose of morphine, the patient was taken, everybody was started on 30 milligram of methadone, and each patient had very good pain relief. So that means the NMDA receptor is also involved uh, in the formation of tolerance. So that's why all these patients had good pain relief when they were started on methadone. Okay, so that's another thing which we have to understand. Methadone can prevent and reverse the tolerance. And you also know that, and because of this NMD antagonistic property, it would be a good medication for treating neuropathic pain. Okay, so we talked about two properties. One is the agonistic action on opioids, and the other one is NMDA antagonism. So now we have a 50-year-old woman who is diagnosed with carcinoma of the breast and underwent modified radical mastectomy, radiotherapy, and chemotherapy. And she has local recurrence and has severe pain, which is radiating to left arm. She's on tramadol every 6 hourly, 100 milligram, and also on amitriptyline, 100 milligram HS. She is also receiving fluoxetine 20 milligram BD for the depression. Okay, so this patient presents to you with agitation, anxiety, restlessness, disorientation, diaphoresis, hypothermia, tachycardia, nausea, vomiting, and tremor. On examination, there is muscle rigidity, hyperreflexia, myoclonus, dilated pupil, ocular clonus. What is the problem with this patient?
Serotonin syndrome.
Yeah, so that's right. So what is serotonin syndrome, and when does it occur?
When more than 2 or more serotonin receptor drugs are given.
Yeah, okay, very good, Dr. Ahmad. So, if you give methadone along with the following medications, or not only methadone, any medication which can inhibit the reuptake of serotonin. If you give it along with other medication which also inhibit reuptake of serotonin, it can produce serotonin syndrome. And methadone, as I told you, it can inhibit the reuptake of noradrenaline and serotonin. Tramadol is another opioid which also has the same action. Tramadol acts on opioid receptors, but in addition, it inhibits the reuptake of noradrenaline and serotonin. That is, it has some tricyclic antidepressant property. So here the patient was taking tramadol. You can see here, she is on tramadol along with amitriptyline, which is another drug which can inhibit the reuptake of noradrenaline and serotonin. And fluoxetine is an selective serotonin reuptake inhibitor. So all these drugs are inhibiting the reuptake of noradrenaline and serotonin, which can cause serotonin syndrome. And the chance of serotonin syndrome is high if you give methadone along with these drugs. And it is medium when you give it with citalopram, etc. And the chance is low when you give it with mirtazapine, bupropion, nortriptyline, etc. So you have to understand it is not only the problem with methadone, but also any other medication. When you combine 2 or more drugs which inhibits the reuptake of serotonin, it can cause serotonin syndrome. And it is very important for us to recognize, okay, this patient has serotonin syndrome. So how do you understand it is a serotonin syndrome? There are many signs and symptoms. The patient might be agitated, restless, confusion. Patient can have nausea, vomiting, diarrhea, tachycardia, hyperthermia. Okay. Then patient can have tremor, brisk reflexes, hyperreflexia, cogwheel rigidity. So if you start any patient on methadone, and if the patient is also getting a tricyclic antidepressant like amitriptyline, and if he presents with agitation and hyperthermia, you have to consider whether it is a serotonin syndrome or not. Okay. So now this is another patient, a 70-year-old man who is on methadone, 50 milligram every 12 hourly for the last 2 months. He is diagnosed with carcinoma of the buccal mucosa and is undergoing treatment. Now he has fever and also has restlessness. So on investigation, the problem was he has urinary tract infection. Okay, so he was treated with the injection ciprofloxacin, and because of restlessness, he was given haloperidol. Okay, and he started complaining of palpitation and syncope. And the physician took an ECG, and it shows like this. What is it?
This is torsadis the pointus.
Yeah. So this is Torsades points. So why this patient developed Torsades points? So we will come to that later. But so you have to understand, I talked about the 3 properties of a methadone which are beneficial, and one property which is very fatal, that is the action on human either agogo related gene channel. So methadone can actually increase the QT interval, which can lead on to torsade points and sudden death of the patient if it is used in higher doses. Okay. So this is a study conducted by MD Anderson Cancer Center, where they recruited 100 cancer patients who has severe pain and started on methadone, and they took serial ECG. When they started, they took an ECG, another ECG at 2 weeks, then at 4 weeks and 8 weeks. And what they found out was, you can see the dosage range of methadone was 3 to 90 milligram, and the median dose was 23 milligram. And they found out that with this dosage, none of the patient developed ventricular fibrillation or torsade points. So this is one study which says if you use less dose of methadone, the chance of developing ventricular fibrillation or torsade points is very minimal. So usually for pain relief, we use less than 50 milligram per day. Okay, so the chance of producing torsade points with methadone is less. Even though you might have heard about that, okay, methadone produces torsade points and it can cause sudden death. But most of the studies were on patients who are taking oral substitution therapy with methadone. And these patients would be on very high doses of methadone, maybe hundreds of milligrams of methadone, which can obviously cause torsade points. And you also understand that it is not only methadone which can produce torsade points. There are many other medication which can produce torsade points. And when you use methadone along with these medications, then the risk increases. So you can see on the left hand side, there are many medications which we use in palliative care very commonly. Like there are some antibiotics, fluoroquinolones, that is ciprofloxacin, then levofloxacin, then macrolide antibiotics, azithromycin, clarithromycin, erythromycin, then SSRIs, citalopram, antipsychotics like haloperidol, then 5-HT3 antagonists like ondansetron. So these are the medications which we need to use very commonly in palliative care. So when you start a patient on methadone, please see whether the patient is on these medications. And it is not possible for you to remember all these medication. So it is better to take a printout and paste it somewhere you can see before you start on methadone. And I will, okay, this we already discussed at first. Okay, now what are the pharmacokinetics of methadone? Like morphine, it is also absorbed from the upper small bowel. But compared to morphine, methadone has a higher bioavailability of about 80%. And it can also be administered sublingually as well as parenterally. So what are the routes through which you can administer morphine? What are the routes through which you can administer morphine?
Morphine can be given as oral, parenteral, that is IVIM,
Yeah,
then parectal,
yes.
suppository.
Okay, suppositories are not available, but it can be given parenterally. Yes. Can it be given sublingually? Can morphine be given sublingually? It is not advisable to give morphine
It's
sublingually.
bitter in taste, so might
Uh,
affect the.
Yeah.
But some gingival preparation is available of morphine.
Uh, uh, at least in India, it is not available. And if you look at the literature, it says it should not be administered gingivally or buccally or sublingually. Because nobody knows how long it is going to take for absorbing from gingival, buccal, or sublingual route. So it is not advisable. So that's one difference with methadone. Methadone can be administered sublingually, whereas morphine is not advisable to given sublingually. Okay. So now, when you administer methadone, what happens? It is slowly absorbed into the blood, and for the first 2 to 4 hours, you can see it in the blood. I'm talking about a patient for whom we are administering methadone for the first time. So for the first 2 to 4 hours, it is seen in the blood, but immediately after this, it disappears into tissue binding sites. So all the methadone will be going into the tissue binding sites, and you can see that methadone is getting saturated in the tissue binding sites. And once it is saturated in the tissue binding sites, then a small portion of the methadone will be released into the systemic circulation. And with this small fraction, that will give pain relief. So to get saturated all the tissue binding sites, it will take about 5 to 7 days. Okay, so that means for the first 5 to 7 days, or methadone will take at least 5 to 7 days for giving proper pain relief. So that's one of the most important thing, which is um, as compared to morphine, because morphine will be giving or morphine, the blood level of morphine will be stabilized in 24 hours. So we can increase the dose of morphine every 24 hours. But in case of methadone, the blood level will be stabilized only after 5 to 7 days. So you should not increase the dose of methadone before 5 to 7 days. But in patients who are elderly and patients who has a liver failure, it may take even up to for 2 weeks. So in elderly and patients with liver failure, it is better to wait for 2 weeks. So this is the most important thing that you have to understand about methadone metabolism. So now, how is it metabolized? It is metabolized by the cytochrome P enzymes. There are many enzymes involved in the metabolism of methadone. But you also understand that there are many other medications which are metabolized by the cytochrome P enzymes. So that means they can have many drug interactions. So that's another problem. We know that it can produce increased QT interval if it is combined with medications, which can also produce increased QT interval. But here there is another problem. Many drugs are metabolized through cytochrome P enzymes, and methadone is also metabolized through cytochrome P enzymes. So there can be interaction. Either it can induce the metabolism or it can inhibit the metabolism of methadone. So let's see what are the medications which can inhibit or induce the metabolism of methadone. So, and grapefruit, protease inhibitors. What are protease inhibitors? Can you give any examples? Protease inhibitors.
HIV medicine like lamivudine or something.
Yeah, very good, Dr. Abish. So, antiretroviral medications that are protease inhibitors. Then azole antifungals like fluconazole, ketoconazole, etc. Then cimetidine, cyclosporin, macrolide antibiotics, erythromycin, clarithromycin, etc. Amiodarone and non-hydropyridine calcium channel blockers like verapamil and diltiazem. So all those medications are cytochrome P inhibitors. So it will inhibit the cytochrome P with the result that you will get more methadone in the blood. So there will be increased methadone levels in the blood, which can lead to toxicity. So you have to be very careful. Are you giving any macrolide antibiotics with methadone? Are you giving azole antifungals like fluconazole, which is very commonly used, isn't it? So be careful. And there are some other medication which can reduce the methadone levels in the blood, like smoking, phenytoin, phenobarbital, oxcarbazepine, carbamazepine. All these can reduce the blood levels of methadone. So if you are combining these medications with methadone, you have to watch whether this patient is developing any withdrawal reaction, because the blood level of methadone will be reduced. Okay. But that was not the only medications which can increase or decrease the methadone levels in the blood. There are a lot of others you can see here, and not possible to remember all these medications. But see, there are a lot of medication which we use commonly. And now, how is methadone is excreted from the body? It is mainly through bowel, okay, and minor amount through urine. So it is supposed to be a safe opioid in patients who have pain with renal failure. So you know that morphine can accumulate in patients with renal failure, and we have to be very careful when when morphine is used uh, in patients with pain who has renal failure. But here, methadone can be used very safely in patients with renal failure. And the duration of action of methadone is 8 to 12 hours. Sure. So you need to give it only TID or BD. But what is the duration of action of morphine?
Morphine has to be given every 4 hourly.
Yeah,
It's
morphine
4
has to be
hourly.
given every 4 hourly. Okay, now we'll move on to the patients for whom we can start on methadone. So methadone can be used as an adjunct. So if the patient is on any other opioid, suppose the patient is on morphine every 10 milligram 4 hourly, and patient has good pain relief most of the time, but by about midnight the patient is waking up because of pain, and in such patients you can use a small dose of methadone like 2.5 milligram, and that patient will have good pain relief. So if methadone is used in small doses along with other opioids to give pain relief, that you can call it as an adjunct in that situation. And uh, there are you know that there are some patients you have started them on tramadol, gave morphine, switched on to fentanyl, but no pain relief. So in such cases, we can say that pain is refractory to other opioids, and in such patients, methadone is a good medication. And patients who has pain with significant renal impairment, because mainly the methadone is excreted through bowel, and as the dose duration of action of methadone is 8 to 12 hours, we can convert, probably if the patient does not get proper pain relief with 4 hourly morphine, you can convert it into methadone, which need to be given only BD or TID. And we saw that there are some patients, in the previous slides, we saw that patients who were on thousands of milligrams of morphine equivalent, because they develop tolerance. So in patients who has high opioid tolerance, and in rarely opioids can produce opioid-induced hyperalgesia, and in such situation, methadone is the drug of choice. And if the patient has poorly controlled opioid-induced adverse effects like delirium, myoclonus, extreme drowsiness, so in such situation, methadone is useful. And true morphine allergy, because methadone belongs to another chemical class. So methadone can be safely administered in patients who are allergic to morphine and patients with complex neuropathic pain. So our patient with Ewing sarcoma, who had actually type of complex neuropathic pain, isn't it? Because she received tricyclic antidepressants, gabapentinoids, uh, epidural, no pain relief. So that patient had complex neuropathic pain. So these are the appropriate candidates for whom we can start methadone. And which are the patients for whom we should not start on methadone? If the patient gives a family history of sudden unexplained death in the family, because congenital QT syndrome can run in families. And if the corrected QT interval is more than 500 milliseconds, what is the normal QT interval, corrected QT interval?
350 to 450.
Okay, yeah. So in males, it is up to 450 milliseconds, and females, it is up to 460 milliseconds. So if the patient is unable to express whether he is having pain or does he or she is having pain relief. So if the patient is having poor cognitive function like dementia, we should not start. There should be a reliable caregiver to administer methadone. Okay. And if you are unable to follow up the patient, if the patient is having acute pain crisis, or you know that methadone will take about 5 to 7 days. So if the patient has acute pain, it would be better to start a patient on opioids like morphine or fentanyl. So how do we monitor patients when we start them on methadone? At the baseline, if you are going to start a patient on methadone, you can take an ECG to understand what is the QT interval. And electrolytes like potassium, magnesium, and calcium also need to be done, because hypocalcemia, hypomagnesemia, and hypokalemia can produce increased QT interval. So that's the importance of doing and finding out the level of electrolytes. And once you start the patient on methadone, then ECG can be repeated after 2 to 4 weeks. And once the dose of methadone reaches to 30 to 40 milligram, another ECG can be done, and another when the dose reaches up to 100 milligram per day. But this is not a hard and fast rule. And most importantly, whether you should do any investigation like ECG or electrolytes, it all depends on the goals of care. Whether the patient is receiving any curative treatment, then we should aggressively monitor the patient. But if the patient is receiving only comfort care, then probably we need not be much aggressive, and we can even do away with all these investigations, because our goal of care is comfort. So this is the methadone, the forms of methadone available in India. It is available as tablet as well as syrup. Tablet is 5 milligram, and syrup is also 1 ml containing 5 milligram. Okay, now we will move on to methadone conversion. How we can convert the first equianalgesic conversion table, which I told you was used previously. We don't use it now. Okay. So this is the method which we use now. So this is from a consensus white paper by hospice and palliative care physicians. So if the patient is opioid naive, so if any patient is taking less than 60 milligram of oral morphine or equivalent per day, can be considered as an opioid naive patient. And if you want to convert this patient to methadone, start him on 2 to 7.5 milligram of methadone per day. If the patient is taking 60 to 199 milligram of oral morphine equivalent per day, and if less than 65 years old, the conversion ratio is 10:1. So 10 milligram of morphine would be equal to 1 milligram of methadone. And if the patient is taking more than 600 milligram of oral morphine per day or more than 65 years old, the conversion ratio is 20:2. So even if it is like this, there is no situation where you should start a patient on more than 40 milligram per day. So patients might be on, we saw patient is on 12,000 milligram of morphine. But if you divide it by 20, you will get some 600 milligram of methadone. But you need not start. You need to start maybe 30 milligram or 40 milligram. That's the maximum initiation dose of methadone. Okay. And now we'll move on to some real patient stories. So this is a 37-year-old man who was diagnosed with carcinoma of the buccal mucosa, and he also had a second primary papillary carcinoma of the thyroid, for which he underwent surgery and radiation. And then he had a nodal recurrence for which he underwent surgery. So you can see the patient here who is sitting with his head down. He is describing a pain which is starting inside the left ear, going to lateral side of the forehead, and then to submental region, which he described as a pricking type of pain and scoring 10/10. So you can see this pain is in the area of mandibular nerve distribution. It is starting inside left ear, going to lateral side of forehead, and then to submental region. So this is a neuropathic pain. So that also in the mandibular nerve distribution area. So the treating team attempted mandibular nerve block 3 times, but there were no pain relief. So they started him on injection morphine and had toxicities, then reduced the dose of morphine and started on tablet of morphine like 10 milligram, 15 milligram, 10 milligram and 30 milligram with 10 milligram SOS. Even with this dose, the patient had toxicities. So he had a delirium and myoclonus. They also tried him on various adjuvants, but there was no pain relief. So this is the prescription of that patient. Tab morphine 10, 15, 10 and 30 along with pantoprazole, ciprofloxacin, escitalopram, serratiopeptidase, diclofenac patch every day, paracetamol 650 milligram, 1 SOS. So is there any indication to start this patient on methadone? Is this an appropriate candidate to start on methadone? Anybody?
Yes, he can be started on methadone, but drug and interactions has to be carefully looked out for.
Yeah, thank you, Dr. Kalyani.
Since he's already on ciprofloxacin
Mm.
and already on escitalopram.
Yeah, very good observation. But what are the indication to start on methadone?
This patient is not responding to morphine in spite of a lot of total dose,
Okay.
and he's also having no pain relief and toxicities.
Yeah.
He's
Any?
also
Uh,
he's also on escitalopram, I think for depression, probably anxiety.
Okay. Thank you. So you told about indications, but there is one more indication. The first one is complex neuropathic pain. And as you told, morphine toxicity and not responding to other opioids. So these are the indication to start on methadone. So before starting the patient on methadone, what all should we ask?
Get the CG done.
Sorry?
Get the ECG done.
Yeah. We can do an ECG, but do we need to ask or need to find out anything from the history?
From history, we can ask for sudden cardiac deaths in his family.
Yeah. Is there sudden unexplained death in the family? Yeah.
We can also ask for any history of seizures in the past. Or
Okay. So two important things is one is history of sudden unexplained death in the family, and is there a reliable caregiver to administer methadone? So these are the two important things which we need to ask. And ECG and electrolytes, as I told you, it all depends on what is the goals of care. So this is a patient who has two primary malignancies and nothing is under control. This patient is requires only comfort care. So actually ECG and electrolytes is not necessary, but if you are a beginner, then better to do an ECG and electrolytes, which will give some peace of mind to you. Okay, so these are the medications, and you told that ciprofloxacin, escitalopram, all those can have interaction with methadone, but even pantoprazole has some interaction. Okay. So how do we calculate the dose of methadone in this patient? Or can you calculate the dose of methadone required for this patient? I'm giving you 2 minutes to calculate the dose of methadone needed for this patient. Okay, I can see there are some response in the chat. Dr. Kalyani says methadone 6.5 milligram per day. Okay. So this patient is taking total 65 milligram of morphine, isn't it? So what is the what is the potency if the patient is taking morphine dose in between 60 to 199 milligram, then the conversion ratio is 10:1. And the patient is less than 65 years. So the conversion factor is 10:1. So 65 divided by 10, it would be 6.5 milligram of methadone. So if it is tablet of methadone, how do you start? What dose would you give? It would be tab methadone 2.5 milligram BED. Or if you have only syrup, then you can give, you can dilute the syrup and can give methadone 3 milligram BED or 2 milligram TID. Okay, but tablet you can make it half that is 5 milligram, you can administer only 2.5 milligram BD. But what should be done with the morphine? Here we know that the methadone will take about 5 to 7 days for giving proper pain relief. So till that time, we should continue morphine on a 4-hourly SOS basis. Okay, it is not 4-hourly and SOS, it is 4-hourly SOS. So it is tab morphine 10 milligram Q4H SOS. And you also need to give bisoprolol along with because this methadone is also an opioid, strong opioid, which can produce constipation. So the prescription would be like this. Methadone can be 2.5 milligram BD and morphine on 4-hourly SOS basis along with paracetamol and erythromycin. Azithromycin you need to, he was on ciprofloxacin, which you need to stop because there is interaction. So instead of ciprofloxacin, you have to substitute it with some other antibiotics which does not have much interaction like amoxicillin. And actually this patient was on 10 milligram BD escitalopram, and the treating team started him on escitalopram thinking that this patient has severe depression and that's why he is not getting pain relief. But actually that was not depression, that was severe pain itself. So once he was started on methadone, he got good pain relief. Okay, so this patient had very good pain relief till his death. Dr. Kalyani,
Sorry, I'm interrupting you.
please.
As you had mentioned regarding this patient, she was given a nerve block also,
Yeah.
but why didn't that give her relief?
So I don't know, but what we have to understand is the nerve blocks are not the permanent solution to the pain. And many times nerve blocks, the effect is variable. Sometimes it will give you relief for some time, some weeks or months, and sometimes it might fail. There may be many reasons, but I don't know why this patient didn't have pain relief.
Okay, sir.
Okay, so now we will move on to another patient. This is a 39-year-old woman with advanced carcinoma of the pancreas uh, who was receiving chemotherapy but stopped because the disease was progressing and was receiving palliative care. And her main complaint is pain, and you can see that her pain starts on the left lateral chest going on to the back, and her pain score is 10 by 10. She described it as a stabbing type of pain, and she's getting some pain relief when she takes morphine plus tramadol and paracetamol. The pain reduced from 10 by 10 to 7 by 10. And these were the medications she was getting: tab morphine 20 milligram 6 hourly, injection tramadol 100 milligram IV TID, paracetamol 1 gram 6 hourly IV, gabapentin 100 milligram TID, amitriptyline 25 milligram HS, bisoprolol 5 milligram 2 HS. And with this medication, she had myoclonus. Do you think this patient would benefit from methadone? Or what are the indications for methadone in this patient? Okay, one is opioid toxicity, isn't it? She had myoclonus. She has neuropathic pain, and she is on tramadol and morphine, and there was no pain relief. So it is refractory to other opioids. So do we need to do any investigations? Actually not. So what would be the dose of methadone in this patient? Can you calculate? So these are the medication she is receiving. So age is 37 or 39. Yeah, I think 39. So I can see the answers 8 milligram. Okay. So I think there is something which you need to be careful here. You need to convert all the opioids into morphine equivalent dose. Okay. Here, patient is taking morphine, which is an opioid, but she's also taking tramadol, which you need to convert into equivalent dose of morphine. So here, morphine is 80 milligram, but she is also receiving tramadol, 300 milligram. So you have to convert that into equivalent dose of morphine. So the potency of tramadol is 1 by 10 as compared to morphine. So 300 divided by 10, that would be equivalent to 30 milligram of morphine. So the total morphine equivalent she is getting is 110 milligram. So her age is 39 and the dosage is between 60 to 199 milligram of oral morphine. So the conversion ratio would be 10:1. So the total dose of methadone would be 11 milligram. So you can start with, if you have only tablet, start with 5 milligram BD. And are there any concerns with the present medications? Amitriptyline has some interactions with methadone. So, but here the dose is very small. It is only 25 milligram HS. So either you can stop it or you can continue amitriptyline along with methadone. Once she has good pain relief, stop amitriptyline. So this patient, actually this patient was a nurse who had 2 kids, and she was very depressed, and again was unable to do anything, restricted to the house itself because of severe pain. And she was started on methadone 5 milligram BD, morphine on a 4-hourly SOS basis, and continued other medications. She had excellent pain relief. So once we started her on methadone, she was able to come out, and she was socially very active. She was very happy with methadone. She got such good pain relief. Okay, now we have another patient, and this is just for calculation purpose. This is a 40-year-old man with advanced malignancy, with spinal cord compression, T12, and received radiotherapy to the spine. He is complaining of burning pain on both lower limbs, which is continuous, and scores 9 by 10. He is on tab morphine 40 milligram 4 hourly, no pain relief. And you want to convert this patient into methadone. What would be the equivalent methadone dose? What would be the dose of methadone? Cannot see any response.
So we are trying to find if there is a catch in the problem.
No, nothing.
We're
There is
getting
no
a
catch.
total dose of 12 milligram per day according to conversion.
There is no catch.
Oh,
Just
sorry, 16
calculate.
milligram. 16 milligram per day, correct.
16 milligram per day. Okay. So the total dose of morphine is 240 milligrams, isn't it? 40 into 6. 240 milligram. So what would be the conversion factor? Patient is taking more than 200 milligram of oral morphine, or if the patient is more than 65 years old, you have to use 20:1. So it is 12, isn't it? So you can start patient either on tab methadone 5 milligram BD, or if you have syrup, start on 4 milligram TID along with morphine. Okay, so these are some websites you can visit to see to understand more about QT prolongation medication and medications which can interact with methadone. And the Indian Journal of Palliative Care had come up with a supplementary issue on methadone in 2018. And if you are interested to know more about, please go and visit this. And this is another useful paper which all of you can download: Safe and Appropriate Use of Methadone in Hospice and Palliative Care, Expert Consensus White Paper. And this is the method which we are using presently. When we started started using methadone in 2018, we started methadone or used methadone only in 5 patients. But now I think we have more than 30 patients on methadone. So once you are comfortable with methadone, then there would be a subset of patients who would be benefited with the use of methadone. But you need to be aware of a few important things. One is, it is not like morphine. It will take about 5 to 7 days to get proper pain relief. So you should not increase the dose of methadone before 5 to 7 days. There are many drug interactions. So it is always helpful to keep the medication list maybe in your consultation room to see whether there are any medication which is going to interact with methadone. Then, even though everybody talks about QT interval prolongation and torsade points and sudden death. If you use the methadone less than 50 milligram per day, the chance of producing the torsade points is very, very minimal. And always select the patient group for starting methadone. Yeah. Yeah, that's it. Thank you. If you have any doubts, you can ask me.
So that was one question from Dr. Aditi. Do you have any short form for this? Because conversion is always practically not possible.
I don't know what does was any short form. No, I don't know any short form for conversion. But I don't think that is much difficult to remember. If the patient is taking less than 60 milligram of morphine per day, then the conversion ratio is, or you can start with 2 to 7.5 milligram per day of methadone. If it is between 60 to 199 milligram, and if the age is less than 65 years, conversion ratio is 10:1. And if the patient is taking more than 200 milligram of oral morphine equivalent, or if the patient is more than 65 years old, conversion ratio is 10:1.
So Dr. Dilip is asking in which indication it is a drug of choice.
So we talked about many patients who are appropriate candidate for methadone. I cannot say a single indication, but we talked about many indications. If a patient has severe pain with renal failure, that might be an indication. If the patient has complex neuropathic pain, if the patient has true morphine allergy. So there are a few indications in which we have to use methadone.
Any more questions? Anybody would like to unmute and ask? Are opioids a contraindication for patients with metastasis to brain?
Yeah, that's a tricky question, because opioids can cause carbon dioxide retention, and it can add to patient may become drowsy or something like that, increased intracranial tension. But if you look at from the practical point of view, if the patient is receiving only comfort care, most probably if the patient has a brain metastasis, then the first drug of choice would be dexamethasone, which would definitely going to reduce the intracranial tension, and that will give pain relief also.
అంతే ట్యూషన్
But if the patient is not getting proper pain relief with steroids and paracetamol and other medication, then we have to use opioids. And many times that will not produce much problems.
So methadone is also used in substitution therapy or maintenance therapy in addicts. So the same formula for analgesia can be used for de-addiction.
So methadone available for oral substitution therapy would not be available for analgesia, but I don't know what formulation is being used for oral substitution therapy. I have not seen, but I know that it is being used. But as an analgesia, it is available only in tablet and syrup form, which is 5 milligram tablet and syrup containing 1 ml 5 milligram.
So if patient is not responding to morphine, not responding to tramadol, if methadone is having so many drug interactions, can we try fentanyl before using methadone, or there will be cross tolerance with fentanyl as well?
Um, Actually, even though both of them are acting on mu receptor, it is said that there is no cross tolerance. So you can try, but if you look at from the practical point of view, if the patient has neuropathic pain, if the morphine is not providing pain relief, most probably fentanyl may also not give pain relief. So it is true that methadone has many drug interactions. So it is our duty to see or to make the prescription very simple. So there will be a lot of medication the patient is taking. So see what all medication the patient is taking and rationalize it.
So, and also there are many congeners of opioids, like we have pethidine, tramadol. So, what all have been tried, or what we can restrict ourselves to trying, because there are many opioid congeners.
Yeah. So and there are many opioids available, but in chronic pain, usually used opioids are, if you look at the WHO analgesic ladder, in the second step, we have opioids for mild to moderate pain. So tramadol, tapentadol, codeine, and dextropropoxyphene. These are the four opioids which are used, but nowadays dextropropoxyphene and codeine are not used. People are using more of tramadol and tapentadol. And in the third step, morphine, fentanyl, and methadone are used commonly. So, pentazocine, which is a mixed agonist antagonist, um, which is not commonly used because it is available only in injectable format, injectable formulation, and it is an agonist antagonist. So it has a ceiling effect for analgesia. And buprenorphine is also available, which is again a partial agonist. And it is available as tablet as well as sublingual tablet as well as patch. People are using patches, but it is very costly. 5 microgram per hour patch, which is equivalent to 12 milligram of oral morphine per day. So that is a 5 microgram per patch and 10 microgram per hour patch is available. But the cost is like in the range of 1,000 rupees. If you give morphine for that patient for 1 week, that would cost only maybe maximum of 50 rupees. So a pethidine is again available, which is only available as injectable form. And so in case of chronic pain relief, patient who require pain relief for long term, the injectable format are not advisable. Injection pethidine, it even can cause or accumulate even in patients with a normal renal function, and it can produce seizures, and it is not used for patients who has chronic pain. So even though many things are available, we use fentanyl, methadone, morphine. These are the three strong opiates, and tramadol and tapentadol are the opiates for mild to moderate pain, which is commonly being used.
Will methadone cause shivering, sir?
Shivering. I have not heard about it. Do you have you heard about it, or have you seen?
No, I have not seen. Just asking that because some opioids are shown to show some sort of shivering in patients.
I don't know whether it is myoclonus, because opioid toxicity can cause myoclonus. That means myoclonic jerks. These jerks can affect a single muscle or group of muscle or part of a body or whole body. Whether it can manifest as tremor or not, I'm not sure.
Okay, sir.
Thank you, everyone. I hope there are no more questions. Thank you so much for such a wonderful interactive session. Thank you, Dr. Sunil, for joining us today and for that wonderful session. Over to you guys.
Thank you, Dr. Sunil sir and Dr. Hashmat ma'am, for the wonderful session. Thank you all for your participation and time. I hope this session finds you informative, and you got all the insights about management of pain. Thank you all for joining. We hope to see you on the next session. Thank you.